Good morning, good afternoon, good evening to all of you joining from the various parts of the world. My name is Dr. Tlaleng Mofokeng, and I'm the current United Nations Special Rapporteur on the right of everyone to the highest attainable standard of physical and mental health. I'm the current mandate holder since August 2020, and I'm also a medical doctor still in clinical practice, and I'm an abortion provider for 14 years. And I just want to take this moment to say thank you to the organizers for inviting me to share with all of you the space as we discuss and commemorate and mark International Safe Abortion Day. And I'm particularly grateful to join all of the speakers and of course engage with you as the audiences as we're talking about the global theme that safe abortion is essential healthcare. And I think it's so important to keep reiterating that point that abortion access is healthcare, and abortion should be integrated into all levels of health systems. And that in fact, with this hashtag that is being used today, make unsafe abortion history, I think it's important to realize that there's certain commitments that have already been made previously, and the fact that we are still now in 2021 talking about the need to make unsafe abortion history, somewhat a moment of accountability, I guess, where we need to be honest about what isn't working and why some of our efforts aren't working. And I think it's because often we tend to locate the issue of abortion access, and many programmers and many health financing and funders find a discomfort with accepting and saying as much that the issue of safe abortion and abortion access in general is a political issue. And I think the more we remove the issue of abortion from the political discussions, the less we'll be able to reach our goal to make unsafe abortion history. And with that, I just want to start my discussion with you. I'm supposed to engage you on the use of manual vacuum aspirators, which are called MVA in short, in South Africa, and demystifying abortion, and talking about what the MVA itself entails. I know that there are other speakers who will be giving you an actual hands-on training and demonstration on what the MVA looks like. So mine won't be the technical step-by-step instruction, but more talking about the politics in which the service is being offered and what it means to be healthcare providers, to be health managers, health administrators, legislators, and activists and advocates who work in the space, who understand that our role is one of being human rights defenders. The rights of people who have a potential of getting pregnant have always been the first to be eroded, have always been the first to be attacked. And around the world, around the globe, with every election, you almost hear this talk and the way that autonomy is being discussed as if it's a political tool. So I think for us to move on into making unsafe abortion history, we have to start by talking about the human rights element. And it's very important because you cannot just have a safe abortion if the policy and the legislation is not enabling of that. And we need to start first by affirming people and letting them know that they have a right to decide if they want to be pregnant. They have a right to decide how many pregnancies they want. They have a right to decide if they want to end the pregnancy, if they don't want to be pregnant anymore. And it's for us as healthcare communicators and healthcare workers to support people make these informed decisions in how we treat them in the consultation room. And so the issue of stigma and discrimination can be enforced and perpetuated by the legislative frameworks, but I still think there's an important role to be played by healthcare workers, regardless of what legal framework you work in. We have our own medical ethics. We have our own oath that drives and informs our practice of medicine and nursing care, that people, women, adolescents, anyone who needs an abortion, a transgender man, should be able to freely talk to us, to access information, education, as a way for them to exercise their rights to autonomy. And how we then treat them as healthcare providers will either and it should affirm their rights, but also ensure that we offer those services in a dignified manner with confidentiality and privacy, as well as doing everything we can to maintain and to protect their bodily integrity. And we have to remember as well that there are many partners that are involved. Currently, DKT is doing amazing work. And that's why I'm on this panel today to discuss with you and demystify the use of MVAs. We have many other partners who have also endorsed, right, the use of manual vacuum aspirators like the WHO, which is the World Health Organization, and the leading bodies of obstetrics and gynecology worldwide. As much as the tool itself, the MVA, was discovered in the 1970s and the use, goes back there, we have to realize that up to now, there hasn't been the necessary uptake into all health systems, into all levels of health systems. And partly it is because of the stigma that surrounds abortion generally. And so one isn't surprised that the MVA isn't being used as a tool to provide safe abortion for whatever stages of pregnancy a person is in, because I feel that sometimes health managers and people who do health financing and budgeting feel that if they actually resource and fund all of these commodities we need to be able to offer abortion safely, that they're encouraging abortion. And that is completely a misunderstanding of what healthcare services are about. And it's definitely an erosion and abuse of human rights. And I want to say that under the Sustainable Development Goal 3, which is Target 3.7, there is an agreement already by states that by 2030, they are going to ensure universal access to sexual and reproductive healthcare services, including for family planning, information, education, and integration of reproductive health into national strategies and programs. And that is something that is unfortunately far from being achieved. We know that the impact of COVID, all it did was exacerbate the typical barriers faced by adolescents, by women, by non-binary people, by transgender men in terms of accessing sexual and reproductive health services related to abortion care. And so in the latest report that I have tabled for the General Assembly, I speak in detail about the impact of COVID on abortion, the fact that women, adolescents, girls, and all persons capable of becoming pregnant, those rights that they have to make informed decisions that are free and free of coercion and discrimination has not been protected even in this time, and that many states have failed in their core obligation. To go into the MVA itself, it's important to also reiterate the fact that a manual vacuum aspiration, I know historically it's been called a surgical procedure, but I think that gives people a false understanding or an expectation of what that entails. Often when you say someone is going for surgery, it's almost as if there's theaters involved and there's many technical people, surgeons assistants, nursing, floor nurses, and all of those. And with the manual vacuum aspiration, it's really a very basic skill that healthcare providers can be trained in quite easily. And it actually isn't as cumbersome as it's sometimes made to feel. And in fact, the development of an MVA as a tool was precisely to make abortions more accessible, in that they will be provided timelessly so that we don't have to have a theater involved, so that even those in rural peri-urban centers are able to access the service. But it was also to ensure that the procedure itself can be given and be done in a complete manner. If we think about the definitions and the technical medical terms that are associated with abortion, we have what we often call spontaneous abortion, and that refers to an unintentional termination of pregnancy, often called a miscarriage. And then you have what we then called induced abortion, which many of us are servicing clients who choose to terminate a pregnancy. And in my practice, I have tried to not separate between a spontaneous abortion and an intentional abortion, because how I treat that patient, the client, is exactly the same. They all deserve dignity, they all deserve privacy, they all deserve timeous care, they all deserve non-discrimination and equality in the healthcare sector. And I know why often there are those distinctions, because how you then manage a recurrent early pregnancy loss, for example, from a miscarriage, will be very different, right, from someone who's having multiple induced abortions. But I think in terms of the clinical service itself, we need to be very careful of not further stigmatizing those people who have and who choose to have termination of pregnancy. The other important element and other important definition is the issue of incomplete abortion. And incomplete abortion can happen with both spontaneous and induced abortions. And it just simply means that there has been an expulsion of some of products of conception, but not all. And why the MVA is important is that it helps us manage that incomplete abortion, helps us remove those products of conception in the uterus so that the abortion itself becomes complete. And that is what is really the key for me, is that the MVA is able to assist us offer timelier service, but also helps us to make sure that the services we provide are complete and successful. And so the other word I like to use and I incorporated in my clinical practice is successful abortion. And that again tries to minimize the blaming of patients, often when they come for post-abortion care, where we know in some instances, in some countries, even where the legislation is enabling, there's still so much stigma, there's still so many delays with access to services that some people may, out of desperation, go to those people who are selling pills on the street, who are untrained as healthcare providers in how to offer successful and complete abortions using an MVA. And often when they come, either in an emergency state where they need emergency treatment because of complications, or they come at a point where it's not an emergency yet, but they have started the process of termination outside of a health facility without the support of a trained healthcare provider, and they may come knowing very well that they have an incomplete abortion, an unsuccessful abortion. And so the MVA is important in completing the uterine evacuation. The MVA, of course, is important because we don't want patients to come for abortion care, post-abortion care, because they have an emergency. We need to tell patients, and this is why information is so important, because you want to actually give enough information to your patients for them to make informed decisions, even outside of a healthcare facility. Even if, for example, the abortion was induced using medication and the medical abortion was unsuccessful for whatever reason, patients should be able to have information to monitor their own bleeding, monitor the cramping, the abdominal pains, to be able to tell us, even before sepsis happens, even before prolonged bleeding happens, that in fact there may be something that didn't go well. So I think the NVA, for me, remains a tool that should be available and accessible in all primary healthcare settings, secondary, third, and quaternary healthcare, because it really is a game changer in terms of how we manage abortions, whether they are successful. What I mean, in fact, what I'm saying is it helps us manage abortions, whether they are unsuccessful or whether they are incomplete. It doesn't matter what terminology you use, but the MVA remains the single most important tool in the hands of a trained healthcare provider to make sure that women, adolescents, girls, anyone who has the potential of getting pregnant is assisted without delays. There are other use, of course, of an NVA, such as endometrial biopsy and sampling for diagnostic purposes. And, you know, it's important also to talk about the instruments that we use, right? So that when the health manager says, well, we won't buy NVAs here because we don't do abortions, to be able to say to them that, in fact, there are many other uses for the MVA. And I think that's one way of demystifying and destigmatizing even the tools of trade that we need as healthcare workers. It's to know that there are more than one users of a manual vacuum aspirator. And I know Prof. Mhlanga is going to go into the details of the different components of the MVA, the different sizes of the cannulas and how you measure, and those being very important. I think another important point to make is that the MVA is affordable, right? There is often this sense that women who need abortions are putting a burden on a healthcare system, and we are demanding that other services, don't happen because we want abortions whenever we want them. I think that's also part of the demystification that needs to happen. The MVA is FDA approved. It can be reused multiple times, up to 25 times, with the necessary disinfecting tools and methods. And for me, it still remains the biggest option, and the one that makes the best sense, and it's the best value, not only for the financing and health systems, but it's also the best value for patients themselves, for our clients themselves. They can return to work quicker depending on what lifestyle they have. For example, I've had to care for women who are flight attendants, and they will fly into the country and they're obviously on schedule. And because of their lifestyle and the work that they do, they opt for the manual vacuum aspiration as opposed to medical abortion, because we don't, and they also don't want to be bleeding, for a few days, sometimes a week, 2 weeks, while they are on duty, while they're traveling across time zones, across different countries. And so I think it's important to also think of an NVA in terms of the bigger patient profile. What does the patient need for their own personal good, but also for perhaps the way they work? I've had to assist women get abortions who are minors, who work underground. And if any of you know anything about underground mining, is that they go underground for up to 10 to 12 hours at a time. It's very hot, it's very humid. And so many of them will even have complaints about when they are on their usual menstrual cycle, that the pads and the tampons, start to have a particular smell just simply because of the heat. And we know that blood disintegrates, right? And so offering them an MVA, even though they could be a good candidate for just a medical abortion, offering them an MVA would be helpful for them in the type of work environment that they are in. And so just to recap, the MVA is used to remove contents from the uterus. And whether it's an induced abortion, a miscarriage, or an early pregnancy loss, whether you are doing incomplete abortion management, post-abortion care, all of those can be utilized in MVA very successfully. And of course, one of the things that I want to talk about is the fact that with an MVA, and why even the occupational discussion is important, is that it does lead to a reduction of the blood loss. And that is a valid reason for someone to say, yes, I'm a good candidate for medical abortion and the use of pills only. However, I'm opting to also have an MVA because of all these other benefits, right? The procedure time is also less. And that it's important to also note that many women have accepted the use of NVA, but I've also found that some women think, and some people think, that if you have an abortion and an NVA wasn't used, that perhaps there's something missing. And this is something we also have to do as healthcare workers, especially when we are recommending or talking about the medication only abortion versus the use of medication plus an MVA, is that the medication only abortion is very successful. And there are many protocols that have been developed by the WHO that we can use very safely up to 10 weeks. And we know, of course, that effectiveness of mifepristone and misoprostol for abortion up to 10 weeks has effectiveness of 97%. So it's a very good option. It's an absolutely good option. Again, there are people who fit this profile who could do the medication-only abortion. However, for a variety of reasons, they may then opt to have a manual vacuum aspiration. And remember that you don't have to have too many days or hours in between. Sometimes what I have found is that where people don't want women, adolescents, and girls to access abortion, they tell them that, oh no, this will take 2 or 3 or 4 days. It really doesn't. It really doesn't. When you have a protocol that you are following and you are working within a health facility that is enabling as an environment for women, you are able to have patients come in the morning after having taken the mifepristone, and you carry on with the misoprostol and actually have a successful manual vacuum aspiration of a patient within the same day. So it's also a myth, right, that abortions take all of this time. And what is important is that the effectiveness of the MVA is 98%, and this was done over a pilot study. And it shows that in 98% of women, there was no need for any further medical intervention. And I think this is something that's really important, is that abortion should be and is a basic primary healthcare procedure. There's nothing overly complicated about it in terms of the technicality of performing an abortion and the use of MVA. And so we need to be able to use these studies and the research in how we demystify abortion, because often people will say, oh, you are just feminists and we want women to have abortions whenever. To be able to say, hold on, there's actually research and evidence that's guiding this. And I think that's one of the most important things. Using a human rights argument and those principles of equality, non-discrimination, bodily integrity, autonomy, those are like good human rights principles to use. But there's actual literal studies that have shown us the research and the evidence that guides the use of surgical or medical interventions when it comes to abortions. So medication-only abortion, very successful. The use of an MVA, also 98% successful as a procedure. And the expense around it, and being an abortion provider for so long, I've had experiences both in the public as well as in the private sector. And in the private sector, of course, this already being something that can be accessed by people who have particular income and particular surplus, I suppose, because we know many women may be working, but they're working in low-paying jobs with no labor protections. And so the little bit of money that they have, even though they are working, goes to other needs. And so we need abortions to still be accessible, to be acceptable, to be of quality in the public primary healthcare facilities, so that regardless of who you are, where you are, the cost shouldn't be the hindrance of why you are unable to get quality abortion services. And I particularly use the cervical block, which is a local anesthetic, and that tends to make the abortion itself a little bit more expensive than if we were not using the cervical block and anesthetic. But again, I think there's an area of advocacy here where all of us should be united to make abortions safe, acceptable, but also comfortable for our patients. I think patient comfort is something that is still lagging behind in many facilities. So they will offer the abortion, there's commodities, there's the medications, there's the MVAs, but we tend to not treat and manage pain properly. And I think that's what adds to the stigma, and that's what adds to a lot of patients coming to us already fearful of what's going to happen to them. And I think what I can say today is, as part of demystifying, as part of destigmatizing, is for us to think very intentionally and properly about how we offer anesthesia, how we offer analgesia to women to ensure that abortions are not just accessible and safe, but that they are also comfortable. They may not necessarily be pain-free, right? Because it does depend on what happens. And people's pain threshold are also very different. So it's important to have these discussions at that time when you are speaking with your clients. And for me, I would, of course, having been an abortion provider in many different settings, I think the conversations about how do we start talking about manual vacuum aspiration are important, because the MVA is a key component of abortion care and service provision. And I think that as we advocate, right, for access to safe abortion, especially in South Africa, where the legislation is so enabling, we have to start having conversations about budgets and spending. Because when you look at what is being budgeted for and what has been spent on the provision of abortion, it tells you that along the lines, there's a bit of dishonesty and there's a lack of accountability generally about why abortion care has been left out of the bigger conversation and the bigger national planning and district planning around sexual and reproductive health services. And I know that even at the start of the COVID lockdown and that level 5 hard lockdown, we were asking the questions about the militarization, right, of the COVID-19 response and how that in itself is going to ensure that abortions are inaccessible. Because even me today, I mean, how many people are just brave enough to say to the military, to the police, that in fact, I'm going to the clinic because I need an abortion, when an abortion service was not even listed as part of essential services. So I think it's important to have these discussions about the context in which abortions happen. And if we are going to make unsafe abortion history, we have to talk about the politics in which abortion happens. We have to demand accountability. We have to demand transparency. We have to demand not just budgeting for abortion services, but also spending on abortion services. And so abortion is a valid family planning method. And I'll say that again, abortion is a valid family planning option. And in the hands of trained healthcare providers, the manual vacuum aspirator really is still one of the most important products that are available to us to ensure that the principles of primary health, that all services must be acceptable, accessible, available, affordable, and of quality, are maintained. And this is why I keep saying that the practice of medicine, the practice of nursing care is in itself a form of human rights defense, because we understand the key principles that are required for us to be able to do our jobs. And the key principles of equality, non-discrimination, the principles of bodily integrity, autonomy, privacy, confidentiality can only be realized as rights if us as healthcare workers know human rights, if we understand human rights, if we understand how human rights should be informing our clinical practice every single day. So as we mark International Safe Abortion Day, we need to remember that the battle is ongoing, and it will only be won if all of us are united in the message, are united in demanding that patients are given information to make informed decisions using evidence and research, and that the understanding of family planning methods and where abortion fits into that happens within a bigger political and economical context. And it's my wish that this session has been helpful to you. And I think if you are struggling as a healthcare provider to understand and have those conversations with your clients about abortion, about manual vacuum aspirators, about the different contraindications, about the indications, about what is best for them, always go back to research and evidence. What is the research showing us? What is it telling us? And what are the different human rights principles that need to come alive as you talk, as you practice, as you give care to patients, whether they are women, adolescents, girls, whether they are transgender men, other the gender non-binary persons. It doesn't matter who is the patient in front of you. If you can remember that human rights principles should be guiding your clinical care and using evidence and research in how you then talk about manual vacuum aspirators, how you make decisions about who is contraindicated, where is the indication for this, and understanding your patient more in depth in terms of the overall discussion and the guidance you will give should be ultimately to ensure that your patient has the best abortion care that they can have. And yeah, I'm happy to have been invited to this important discussion and event as we all strategize and put our efforts, towards demystifying abortion, but also positioning the manual vacuum aspiration as a key component of abortion care and services in South Africa. And with that, I would like to thank all of you so much for your attention. And if you have time, you have interest, you are more than welcome to go on the OHCHR website. And there you will find a link to my General Assembly report that looks at the impact of COVID-19 on sexual and reproductive health rights. And in there, we also talk about access to abortion care at this very difficult time. And so thank you very much and good luck with the rest of the panel. And I'm very excited also to be still learning from Professor Eddie Mhlanga, who taught me in medical school, by the way, all of 17 years ago. And I'm still, so inspired by the work that he continues to do. And I will also be tuning in. So thank you very, very much for your attention.